Hello everybody. My name is Anupam Chandra. I'm a consultant doctor at Akershus University Hospital. We have made 4 information videos on COVID-19 tailored for transplant recipients and persons with chronic kidney disease. I will talk about COVID-19 with focus on persons with chronic kidney disease. This includes persons from mild kidney failure to advanced kidney disease and dialysis patients. Some persons may have a renal disease but normal kidney function. They also have an increased risk of serious illness during COVID-19 and may benefit from watching this video. I recommend that you watch the video with general information before you watch this video. For more information on vaccines, please watch the video focused on the transplant recipients and other persons on immunosuppressive therapy. The risk of death due to COVID-19 increases with age, and fatal cases are dominated by persons above the age of 65 years. This also applies within risk groups such as chronic kidney disease. Age is the strongest risk factor for fatal outcome during COVID-19, but not the only one. Men are at slightly higher risk than women. Compared with the person with normal kidney function, a slight reduction in kidney function does not impose a steep increase in mortality. For persons with more advanced kidney disease, with GFR less than 30, the risk is somewhat more increased and is more than 2 times higher than in persons without kidney disease. For organ transplant recipients and other persons on heavy immunosuppressive medication, the risk is clearly increased and higher than, for instance, cancer or diabetes. Vaccine is voluntary, but we recommend everyone to take the coronavirus vaccine. For persons with renal disease, we strongly recommend to take the vaccine due to the risk of serious illness during COVID-19. All 3 vaccines that are expected to be available in Norway within the next weeks or months are shown to be efficient and safe. For a more thorough discussion on vaccines, please watch the video tailored for transplant recipients after you have finished watching this video. Old persons with kidney disease belong to Norwegian Health Authority Vaccine Priority Group 1 till 3, while other persons with chronic kidney disease should receive vaccine as part of Priority Group 4. Some have renal disease but normal kidney function, like for instance those with glomerulonephritis. This group of patients also have an increased risk of serious illness during COVID-19, especially patients with gross proteinuria. They should receive vaccine as part of Group 4. It is the general practitioner that has been given the task to identify persons belonging to Group 4 and inform the municipality authorities. Vaccination will take place in the municipalities, and you will receive a note from them when it's due time for your vaccine. This has been a tough challenge for the general practitioner, and things might slip. It could take months before Group 1 to 3 have received their vaccine. If everyone else get the vaccine, but you are still waiting for it, you might consider checking with your general practitioner or municipality that you are scheduled for vaccine as part of Group 4. Most persons who catch the coronavirus, even those belonging to a high-risk group, experience a mild infection, but some do not. Many patients wonder what would likely happen if they get serious or critical illness due to COVID-19, while others would not like to hear about it. The next 3 slides focuses on treatment of critically ill patients, so fast forward the video if you do not want to hear this. In short, the virus will attack the cells in the respiratory organs first. In the upper and particularly lower airways, there are many ACE2 receptors that the virus need to intrude our cells. Therefore, the virus enjoys the lung environment. The immune system sends their stormtroopers, the lymphocytes, to the site of infection to start combat the virus. To begin with, this process may be quite harmless, but as times go by and the lymphocytes do not manage to clear the virus, other immune cells will be recruited, like monocytes, that turn into macrophages when they resident an inflamed area. The word macrophage implies a massive appetite, and it's just what it does. It eats a lot of infected cells. The tissue is damaged, thick mucus fills the lungs, and the small airways with alveoli collapse, shown as small gray airways on the drawing. These changes produce stiff alveoli and appear as gray areas on the CT scan. Only parts of the lungs remain well ventilated, which is shown as a light blue air-filled alveoli. The lack of exchange of respiratory gases in large areas of the lungs lowers the oxygen supply to the body. At the same time, the macrophages send out large amounts of signal mediators called cytokines to attract other immune cells to come and join the fight. If this process evolves, you will have a cytokine storm that can attack the lungs, but also other organs in the body, including the kidneys. The cytokines can produce leakage from blood vessels, the blood pressure drops, and becomes too low to sustain oxygen and nutrient-demanding organs like the heart, kidney, and brain. When oxygen and nutrients supply do not meet the demand, we can experience heart attack, acute kidney injury, and disturbed brain function. The virus can also cause collapse of vessels in the glomeruli, and large amount of protein may be lost in the urine. The virus can also cause a direct attack on cells in the proximal tubuli in the kidney, but is not likely to cause many cases of acute kidney failure during COVID-19. The coronavirus stimulates coagulation, causing thrombotic lesions. A number of organs show dysfunction, and some totally fail as a consequence of cytokine storm, lack of oxygen, blood vessel leakage, thrombosis, and the patient eventually needs treatment in the intensive care unit. At the intensive care unit, we try to compensate for lack of oxygen by oxygen supplied through a mask or by the use of a ventilator. Particularly patients with respiratory failure on ventilators, but also other patients with critical illness due to COVID-19 experience acute renal failure and may need dialysis treatment. We administer the anticoagulant drug Fragmin, a low molecular weight heparin, to avoid thrombotic events, and we supply high-dose potent steroids to reduce the immune response using dexamethasone. Some relatives wonder why we put these patients in the prone position, which seems kind of awkward. We do this to ventilate stiff lungs better, as more areas that used to be collapsed revitalize and become air-filled alveoli. Prone position is uncomfortable if you have a dialysis catheter in the jugular vein on the neck, but the alternative is respiratory failure, which is worse. Several experimental treatments have been tested in several cases of COVID-19, and most did not prove efficient. The three most promising candidates, at least I think so, have not been confirmed efficient in large trials, but we expect to hear a lot more about these in months to come. It is reason to believe that antiviral drugs given during the first days of infection, when virus replication peaks, could slow down the infection. They are tested in patients with confirmed early phase COVID-19. Monoclonal antibodies directed towards cytokines could prevent or reduce the cytokine storm. Some monoclonal antibodies show promising results. Others have failed to show any effect. Antibodies directed toward coronavirus harvested from the blood of COVID-19 survivors, so-called convalescent plasma, seems intruding for persons with immune deficiency or receiving heavy immunosuppressive regimens, and therefore a limited ability to produce their own antibodies. We await reports from studies on these candidates with great expectations. COVID-19 may also influence the regular treatment of chronic kidney disease, and I will go through some of the drugs that are much debated here. Erythropoietin-stimulating agents like Aranesp or Mircera could increase the risk of thrombosis, but only a little, and should still be given to avoid anemia. Rituximab blocks B lymphocytes that we need to produce antibodies. Person taking these drugs would likely experience a reduced vaccine response. The alternative drugs to rituximab are other heavy immunosuppressive regimens that would also reduce the immune response. Your doctor will assess carefully which of these treatments you will receive during the corona pandemic, and rituximab should still be given when considered the best treatment for your immunological disease. Methotrexate could affect lung function during COVID-19, and your doctor will assess whether you should temporarily stop this treatment. Several other immunosuppressive drugs, including drugs used in organ transplantation, may also be discontinued, which we address in the video focused on transplant recipients. Hydrochloroquine used in systemic lupus can be used as normal. In the early phase of the pandemic, we thought that this drug could have an effect on the coronavirus, but the results from studies showed no effect. ACE inhibitors and A2 antagonist, that is medication that ends with pril, tec or sartan, can be continued with the expectation of serious illness with either dehydration or acute kidney failure. We thought for a while that these drugs could worsen outcome of COVID-19 due to upregulation of ACE receptors that these drugs are targeted against and that the virus uses to enter the cell. But fortunately, this turned out not to be the case. I can assure you that your doctor will carefully adjust your treatment, including these drugs, during COVID-19. Even though you hopefully soon have received a coronavirus vaccine, you should still adhere to infection control advices. The vaccine protects against serious illness if you catch the coronavirus, and to a lesser degree protect against transmission of virus. Moreover, the effect of the vaccine on persons with advanced kidney disease is uncertain, as they were not enrolled in the vaccine studies. The vaccine immune response is currently evaluated for this patient group in clinical studies. These are demanding times for persons with renal disease, with a lot of uncertainties. The healthcare service is occupied with COVID-19, but that does not mean that we are not interested in helping you with other health matters. Seek help if you get serious problems with anxiety or depression. Many are scared and lonely, but it helps talking to persons with the same experience as you have. The peer work of L&T is available for you. Together, we can overcome the corona pandemic. Thank you for listening.